All right, worst case scenario. You check the mail and certified letter from your biggest payer is on your desk. They ask for medical records and you have 30 days to respond, right? So your stomach drops and you don't even know where to start. So here's the thing. Obviously, if this is the first time you're thinking about an audit and you haven't stayed up on regular coding audits, you're going to be somewhat shooting in the dark because it's too late to fix those issues. You got to get the cases pulled together and sent out. But do you know if you were doing it correctly? So today we're going to talk about practices that survive audits and keep those contracted rates, don't have prepayment reviews so that you are never in a situation where you're questioning your coding. So I will never forget, it was actually one of our first large audits we were asked to help support. It was a couple years ago, multi-provider group, it was a family practice group that got hit with a post-payment audit from a major commercial payer. So the payer's software basically flagged an outlier for incident to billing. And those regulations had, changed in the last 10 years and they weren't caught up on those guidelines. And incident to billing, just for you guys, makes me so nervous when this is done incorrectly. And it was actually years of them billing for this incorrectly. And by the time they got the notice, they were already on the hook for what ended up being a 6-figure payback. And it was painful. It almost shut down their practice. And our focus was getting them an appropriate coding audit, right, to prepare them for the future and avoid this, and then get on a regular coding audit frequency. So they also had a coding review prepayment situation going on, so delayed payments as well. So again, 2 really bad outcomes. And again, they were billing incorrectly. So today we're going to talk about audits a little bit and just some things that you guys can do. Again, there are many different, ways to prepare yourself. It's not always going to be perfect, right? You can still get an audit. You can still be in dispute and still have to fight, even if you're coding correctly, but we're trying to make this as safe as possible. So first, what audits do private practices actually get? So you guys know I live and breathe in the hospital world. In the laboratory space, right, it's one of the most highly regulated spaces in the hospital. So today I'm not talking about Joint Commission. I'm not talking about CAP showing up to inspect your lab, though I am happy to talk about those down the line should that be an interest to you. Would love to hear from you guys on topics you guys would like to hear. info@natrevmd.com does get to me. So today we're going to talk about some common audit types in the commercial payer space, right? So Aetna, Blue Cross, Cigna, United. And they can come in 2 different flavors, right? They can have that prepayment review where they freeze your claims and demand records before they'll pay. And that can happen either on a single claim situation or on a larger prepayment review scenario where they're looking at all of your claims in a worst case scenario before they pay. But to me, that more dangerous or concerning is that post-payment audit where they claw back money that they've already paid you. And so there's also some government audits, RAC audits, which are those recovery audit contractors. And they actually have this 3-year look back period. They get paid a percentage of what they cover. So obviously they're motivated. And then there's another type of audit called targeted probe and educate, which are actually Medicare contractors. And they are typically the start of a much larger investigation and can take years to resolve. So obviously, how does this happen, right? So for some practices that could have an audit request after audit request, right? You have multiple, and payers may be, mining your data and scanning for outliers, right? And you may get a letter that says, hey, you're an outlier for certain high-level codes or modifiers. And so obviously, if your pattern of billing differs from your regional peers, then you may be a target, right? So for an OBGYN practice, that may be making sure that you're correctly billing for those high-risk pregnancies, or maybe you're, billing more modifier 25s on your wellness exams. Again, they're going to use some sort of data AI algorithm in order to identify if you're an outlier. And that often can trigger an audit. So for an urgent care, for example, you may be billing more level 5 E&M codes than the regional average. And while that may be completely justified, your patient mix may warrant that, it just may put a target on your back. And again, that shouldn't say that you should be down coding. It just needs to really make sure that your documentation makes it, right? So if you are using more modifier 25s in either scenario, right? So You just want to make sure that you clearly outline, okay, I had a preventative visit, I am addressing an E&M, and that you're documenting the full E&M review in that note, so that if you do have medical records that are being requested, that you are able to document appropriateness of using those codes. So as you guys know, we all know payers aren't trying to understand your practice. They're playing numbers game. If you stick out and you get audited, then you may get audited. So now there's the wait until we audit strategy, right? So there's the, I'm just going to wait until I get a letter. And obviously you're in a situation where hopefully you're coding appropriately, but if you're not, then it's going to be, a situation. So for most practices, we recommend doing a regular coding audit, at least every 6 to 12 months. And this is not, again, going to be something that's typically included in your billing services. It's typically a carve out or a request. And even if you have coders working on your team coding a portion of your stuff, you want to make sure that there is an independent coding audit that is done, looking at varied types of practices within the types of patients that you're seeing. So even if you have coders on, they're not typically reading all of your clinic charts and notes, right? So you could have a coder on your team who is scrubbing a claim, which is very different than leveling an E&M. So what I mean by that is, say you've got a billing team, they're scrubbing your claim, so they're making sure that you don't have any missing modifiers, et cetera. They're likely not looking at the full note and actually coding it from scratch. It's a very different level of coding. That level of coding typically is a cost per hour or cost per chart in order to do that. And so even if you have coders in-house, they're likely just doing a coding scrub. So making sure that you are picking different types of patients that are seen in your office and doing a 10 to 20 chart audit for each of your physicians or mid-levels is really, really key. So back to our audit, by the time that you get that letter, right, you're scrambling to pull the charts. Maybe it's hundreds of charts, but you're not going to be able to go through and fix all of those, right? It's just too late. So you just have to kind of brace for a potential financial hit, or, while they're doing the audit, you're doing an independent coding audit. So then you can compare notes and fight it if necessary. But again, it's reactive, it's scrambling, it's stressful, and it's not how you want to be handling this. So what is the solution? Just like in the lab world, the hospital world, it's called continual readiness, right? So you guys know, and that's my world I live in. And if you're dealing with Joint Commission hospital inspections, right, you don't wait for inspection timeline or to try and figure out if you're, ready for the checklists, right? You're always in a state of continual readiness. And that is what I recommend for practices in the coding space as well. So today we're going to give a few of those tips. It means that you can find and fix your own problems on a rolling basis with those. And so if you do have a real audit letter that arrives, at least you know that you don't have this 5-alarm fire. Maybe they'll find a few things, but that consistent readiness can be stress reducing. And again, this doesn't mean hiring a team of auditors or buying some expensive software. It is, 10 to 20 audits or 10 to 20 charts per physician per mid-level, 6 to 12 months a year. Obviously, making sure that if you've never had one of these, certainly making sure that you go out and do that. We have some amazing coders who are available to do that, who can also sit with you and educate as part of that coding audit. So again, every 6 to 12 months, 10 to 20 charts per provider. Again, this should be, somebody who's independent from doing the coding actions in your practice. We have it as a separate individual who does just these, and she educates. She's incredible. Obviously, this audit is going to cost you, some money, but again, it could save you tens or hundreds of thousands of dollars to avoid any sort of payback. Action number 2. So once you've done the audit, right, you've identified key things. Next is really understanding and training your staff. So do you have issues with documentation? Do you have certain individuals who are late on signing out their charts or don't sign them out at all, and you're still billing for those, which is a big no-no? Or they're billing, high risk things, level 4, level 5, modifier 25, but then they're not actually documenting the need for that. So you have to kind of have policies and training for your physicians so that everybody's on the same page on what the expectation is. Because at the end of the day, if you are the owner, you're going to be the one who's stuck dealing with that, not a physician employee. So you've got to really have those expectations laid out in writing and make sure that everybody's on the same page. Again, this is not a one-time thing. It's an ongoing discussion that you really want to make sure that when you're doing those audits, those chart audits, that you have education going on and that everybody's on the same page. And then again, if say you do, a big education moment for your physicians, having another audit in 6 months may be a good way for you to double check that everybody's implemented those needs. Another tip is making sure that you have had a hard look with your EMR. Does it capture all the data that you need in order to defend things? So do you have templates that are missing key documentation elements? I highly recommend working with the EMR company so that you can fix those, so that those aren't an issue long term. And then last, want to make sure that you have some way to understand what payers are watching. So again, you don't need to become a compliance at work, but you do kind of have to have an idea of what's on the radar. Highly recommend subscribing to the CMS listservs, attend webinars from your regional Medicare contractor, and making sure that you're getting updates from the commercial payers. We try and provide as many of those that we get notified on as well, but we're not going to see them all. Oftentimes you're on the listserv of all of your different payers. So really important that you guys take the responsibility to do this as well. Again, in partnership with your billing team, hopefully all things are caught. But this is just a lot of information. Obviously, there's a big reason why when we see new denials, right, we're putting those on the issue tracker. We're discussing those with the physician so that if they do need to change how they're documenting for something or how you manage workflow for patients, that can be discussed. So again, audits are painful. Payers are using data to look for those outliers and then go after those practices for an actual audit. So the best way to win is to really understand how are you coding today? Do you need to retrain anybody in your office? And setting that process up again on once or twice a year. All right, so hopefully this episode was helpful. Would love for you to share it with a colleague or a friend. And again, we have a couple different resources. If you head on over to notrevmd.com, we have a book, a billing course that is free at this time. And obviously you're here listening to the podcast. So hopefully this is a help for your practice and have a great rest of your week.